This is part one of a two-part presentation on drugs that affect the heart, blood vessels, and blood volume. Before we start to discuss individual classifications of drugs in the cardiac system, you want to review hemodynamics, specifically do a brief overview of the circulatory system and the regulation of cardiac output. The next two slides will provide this brief overview for you. Please review the circulatory system, what makes the heart pump, what pressure systems are existing in the arterial system versus the venous system. Ask yourself what makes blood flow and how does blood get back to the heart once it's pushed through the peripheral system. Make sure that you spend time going over these key terms regarding cardiac output and the components that contribute to the amount of cardiac output in our body. So, reviewing the equation of cardiac output equaling your heart rate times your stroke volume, understanding what regulates heart rate, stroke volume, preload, afterload, review Starling's law, the baroreceptor reflex, your RAS system, think about hypotension and natriuretic peptide. So in conjunction with pathophysiology, you want to be able to define this terminology. We're going to talk about diuretics. For each of the drug classifications, you want to make sure you understand what is the mechanism of action. So ask yourself, how do diuretics actually work? And for most diuretics, they share the same basic mechanism of action. There is a blockade of sodium and chloride reabsorption that's occurring. And when we block the reabsorption of these prominent solutes, the diuretics can create an osmotic pressure within the nephron. This osmotic pressure prevents the passing or the reabsorption of water passively. So diuretics will cause your water and your solutes to be retained within the nephron, promoting the excretion of both water and solutes. So what we'll see is an increase in urine flow. This is what the diuretics will produce, and it's directly related to how much sodium and chloride reabsorption can actually be blocked. Drugs that block solute reabsorption to the greatest degree will produce the most profound diuresis. Because the amount of solute in the nephron becomes smaller and smaller progressively as filtrate flows through the proximal tubules to the collecting ducts, these drugs will act early in the nephron, and they have the opportunity to block the greatest amount of solute reabsorption. So then we will have a good response to this diuretic. We're going to get the most diuresis from this. However, because the most of the filtered solute has already been reabsorbed by the time it reaches the distal parts of the nephron, the diuretics that act at the distal sites have very little reabsorption available to block. So if you're using a diuretic that works on the distal parts of the nephron, we're not going to have a great amount of diuresis compared to the other. You want to look at the quantitative relationship between the blockade of solute reabsorption and the production of diuresis. Remembering that your kidneys produce 180 liters of filtrate each day, practically all of which is going to be reabsorbed, and this is a normal process. When the filtrate production at this volume occurs, a diuretic will increase the daily urine output by 1.8 liters for every 1% of solute that's being reabsorbed as part of this blockade. So if we have a 3% blockade of solute reabsorption, we're actually going to have a 5.4 liter output of urine a day. and a rate of fluid loss that would actually reduce your body weight by 12 pounds within 24 hours. So 5.4 liters is about 12 pounds. So with the small blockade of reabsorption, diuretics can actually produce a really great effect on your fluid and your electrolyte composition of the body. So we have to make sure we're paying attention to that as well. This process actually has an adverse effect on our ECF, or extracellular fluid. To promote the excretion of water, diuretics have to be able to interfere with the normal operation of the kidneys. And when we do this, they can actually cause hypovolemia because of the excessive fluid loss. Remembering a 3% blockade can actually release 5.4 liters of urine. We can minimize these adverse effects if we use short-acting diuretics. And if we think about how we're timing these drugs, this can allow the kidney to operate in a drug-free manner between the periods of diuresis. Both measures will give this kidney a periodic opportunity to readjust to this extracellular fluid and allow the kidney to compensate for any of the undesired alterations or side effects that are produced under the influence of the diuretic itself. Additionally, because of the hypovolemia and the rapid loss of fluid, we can increase our risk for acid-base imbalances as well as overall electrolyte imbalances in the body. There are 4 major categories under the classification of diuretics. We have loop diuretics, so an example of this would be furosemide or Lasix, thiazide diuretics like hydrochlorothiazide, osmotic diuretics like mannitol, and we have potassium-sparing diuretics. And we have 2 types. We have the ones that are aldosterone antagonists like spironolactone, or we have the ones that are non-aldosterone antagonists, triamterene. Lastly, there is a 5th group called carbonic anhydrase inhibitors. And even though these are technically classified as diuretics, we usually use them primarily to lower interocular pressure and not to increase urine production. But they're still within this classification of diuretics. Because of this, we're going to talk about this group of diuretics a little bit more when we look into the neuro type medications. Now, loop diuretics, these are our most effective diuretics. They're going to get the job done. They're going to allow for the most diuresis. They produce more loss, though, of fluid and electrolytes because of this. And they will promote more fluid and electrolyte loss than any other type of diuretics. We call them loop diuretics because where they work best, or the site of action, is actually at the loop of Henle. Lasix is the most frequently prescribed loop diuretic, and this is going to serve as the prototype for the group. So when we're talking about loop diuretics, we're just going to use Lasix as the example, or furosemide. And furosemide will work on the thick segment of the ascending loop of Henle. And this is where we're going to have that blockade reabsorption of sodium and chloride. And if we block the solutes from being reabsorbed, then we also are going to prevent the reabsorption of water. A substantial amount of filtered sodium chloride is normally reabsorbed in this loop of Henle, about 20%. So when we interfere with this reabsorption, we can produce diuresis. In terms of pharmacokinetics, when we give Lasix orally, we can expect diuresis to begin about an hour after, and you're going to see the effects for at least 8 hours. Oral therapy is used when we need a rapid, when we need a lot of diuresis, but we don't have to really need it immediately, right? Because it's going to take about an hour for it to finally kick in. Furosemide undergoes hepatic metabolism, then it's followed by renal excretion. So important to know. So why do we use Lasix? Well, generally we're trying to use it in situations where we need massive mobilization of fluid. And other than that, this drug should be avoided when we can use other diuretics like thiazides. If they work, we'd rather use something a little less heavy hitting. Conditions that justify the use of Lasix, however, think about a patient that is experiencing side effects of congestive heart failure, like pulmonary edema, or they have edema due to hepatic, cardiac, or renal etiologies. And now they've been unresponsive to the other less efficacious diuretics like a thiazide. We also use it in terms of hypertension. If it can't be controlled with other diuretics like a thiazide, then Lasix needs to be prescribed. It's especially useful when we have patients that have renal impairment, like severe renal impairment, and when the other drugs that are being prescribed, like a thiazide, they're not doing it enough, right? They're not promoting enough diuresis. Even when the renal blood flow and GFR are low, we can use furosemide. Now, if treatment with Lasix alone is insufficient, then you can also add another diuretic. Preferably, you'll put on a thiazide diuretic, and this can be added to the overall medication regimen. There isn't a benefit to combining furosemide with another loop diuretic, so you wouldn't want to use Lasix and Murinex or Demodex. No other reason why, because they're going to still work on that loop of Henle and cause that same type of blockade reaction. So additionally, we have Lasix, but again, we can use these other three that are here, that are listed. They work very much like furosemide. They promote diuresis by inhibiting that sodium and chloride reabsorption in the thick ascending limb of the loop of Henle. All of them can be used for edema caused by CHF, chronic renal disease, cirrhosis, but furosemide, like furosemide, is approved for hypertension. So those are the only two that you would use. So Lasix and the Demodex. You could also use for hypertension. And in the book, you can see the different routes, dosages, and the timing courses. They're on the diagram. You can also see the adverse drug reactions shown on these tables. And the things that you're going to talk to your patient about mostly is hyponatremia, hypochloremia, dehydration, hypotension, because obviously we can use it for hypertension. So if we give too much or there's an adverse effect, it can actually swing the other way and cause them to have a lower blood pressure. Hypokalemia, Loop diuretics can cause ototoxicity. They can promote hyperglycemia, hyperuricemia, a reduction in your good cholesterol, and an increase in your bad cholesterol and triglycerides. You never want to prescribe a loop or a thiazide diuretic with digoxin, any other ototoxic drugs, because we already have a higher risk for ototoxicity. You don't want to prescribe loop and thiazide diuretics with potassium-sparing diuretics, not with lithium, antihypertensive agents, because it's also going to have that effect already, and you don't want to prescribe it with an NSAID. I do want to spend a little bit more time now talking about the thiazide diuretics. Now that we understand a little bit more about loop diuretics, we're going to talk about thiazides and potassium-sparing diuretics. The prototype we're going to use for thiazides is hydrochlorothiazide, and the prototype for potassium-sparing diuretics is spironolactone. And you can see that thiazide diuretics have very similar adverse effects as the loop diuretics that you can appreciate here in this chart. Why would we use a thiazide diuretic? It does have a similar effect as loop diuretics. However, the amount of fluid that can be diuresed is very different. For loop diuretics, we can diurese a mass amount of fluid quicker, like in 60 minutes, versus a very low amount of fluid, and it takes about 2 hours for it to start working. Also, loop diuretics can be effective when our patient has low urine flow. But with thiazides, if your patient has a low urine output, it's not going to work very well. And that all has to do with the mechanism of action and where it is working in the kidney. So hydrochlorothiazides are going to produce urine production by blocking the reabsorption of sodium chloride, but it's going to be at the early segment of the distal convoluted tubules. And this area only allows for 10% of filtered sodium and chloride being reabsorbed, where the thiazide is going to act on the kidney. So the maximum urine flow is pretty low compared to where the loop diuretics work at the loop of Henle. Additionally, if you have a patient that has low kidney function or inadequate kidney function, so think about GFRs less than 15 or 20 mLs per minute, thiazides are not going to work very well. But loop diuretics can be used to promote fluid loss even in patients with severe renal impairment. Again, thiazides cannot do this. Going back to the pharmacokinetics for a second, it does take about 2 hours for the effects to start to be appreciated, and this is after oral administration. And you're going to see the peak effect around 4 to 6 hours, and it'll last about 12 hours. Most of the drug is excreted in the urine. Well, why would we use a hydrochlorothiazide or a thiazide? We use it primarily for edema or essential hypertension. And with essential hypertension, especially with the newly diagnosed hypertensive patient, hydrochlorothiazide is a first-line treatment. We usually start at 12.5 milligrams, and we can increase to 25 to 50 milligrams if that's not working. If we can't control blood pressure alone with a thiazide, then we can use multiple drug therapies as well. Thiazides are the preferred drug for moving fluid or mobilizing edema that's associated with our mild to moderate heart failures. And we can also use it to help diurese patients or move fluid with patients that are edematous due to a hepatic or renal etiology. Now, with our potassium-sparing diuretics, they're kind of in the middle in terms of how much they diurese. They can diurese more than thiazides, but not as much as a loop diuretic. And the reason we use it, or the reason providers like this medication, is that we can actually prevent a total loss of potassium. So it's actually going to help sustain some potassium or spare potassium and cause diuresis. So if you have a patient that already has low potassium, then you wouldn't want to give them a loop diuretic or a thiazide. You'd probably want to start them on a potassium sparing diuretic. However, because of their ability to decrease potassium excretion, we use these drugs often to counteract the potassium loss that's caused by a thiazide and a loop diuretic. So it most often isn't going to be prescribed by itself. We'll use it in combo with the other types of diuretics. With spironolactone, this is also called aldactone, and it blocks the actions of aldosterone, and it's blocking it at the distal nephron. Aldosterone acts to promote sodium uptake, and then it exchanges for potassium secretion. So when we inhibit aldosterone, we're going to have the opposite effect. We're going to retain potassium and increase our excretion of sodium. And so wherever sodium goes or salt, water is going to follow. And this is where we get the diuresis that's being caused by spironolactone. But most of the sodium load has already been reabsorbed by the time the filtrate actually reaches the distal nephron. Also, the effect of spironolactone is pretty delayed compared to the other types of diuretics. It usually takes about 48 hours or 1 to 2 days to develop. Remember that aldosterone acts by stimulating cells of the distal nephron to synthesize proteins that are required for sodium and potassium transport. But if we prevent aldosterone from being able to work, then the spironolactone will block the synthesis of these new proteins, but doesn't stop the existing transportation of the proteins doing their jobs. What we'll see is an effect that is only appreciated 1 to 2 days later because the existing proteins have to live out their life cycle. We use spironolactone for hypertension and edema primarily. Although we can use it alone, we typically will use it in combination with a thiazide and a loop diuretic. Because the purpose of using spironolactone is to counteract, again, that potassium wasting effect that we'll get with the other types of diuretics. We don't really depend on spironolactone by itself to produce the amount of diuresis needed. With our heart failure patients, literature has shown that spironolactone will reduce the mortality and the hospital admissions of patients with severe heart failure. We do have some adverse effects that we need to think about. Well, if it's potassium sparing, we can swing the other direction and actually cause hyperkalemia. And when we have hyperkalemia, we're really worried about fatal dysrhythmias. Whenever we have a patient that is taking a potassium sparing diuretic, we're really paying attention to their potassium levels, their serum potassium. Now, although hyperkalemia is most likely when spironolactone is used alone, we still can develop hyperkalemia even when we're using it with a loop or a thiazide conjunction. If you get a patient's serum potassium and it goes above 5 milliliters, milliequivalents per liter, and we are starting to see abnormal heart rate, we have to discontinue the drug immediately. And we need to think about potassium intake being restricted. Spironolactone also has a non-circulatory system effect. It actually has an endocrine effect. It's a steroid derivative, and its structure is very similar to steroid hormones like progesterone, estradiol, or testosterone. So as a result, we can use spironolactone to achieve a variety of endocrine effects, including gynecologic gynecomastia, menstrual irregularities, impotence, hirsutism, and deepening of the voice. Thiazide and loop diuretics. Think about drug interactions. With spironolactone, we do frequently combine it with a thiazide and a loop diuretic because the goal is to counteract that potassium wasting effect of just using a thiazide or loop diuretic by itself. Because there is a good risk for hyperkalemia, or I should say a bad risk, right? We have to be very cautious on when we're using spironolactone with potassium supplements, salt supplements, because they also contain potassium chloride, or if we're using another potassium-sparing diuretic. Also, this is important, if we're using other antihypertensive medications. So, 3 groups of drugs: the angiotensin converting enzyme inhibitors, or ACE inhibitors, the angiotensin receptor blockers, or the ARBs, and the direct renin inhibitors can actually elevate your potassium levels because they work on suppressing aldosterone secretion. So we never want to use these antihypertensive medications in combination with spironolactone unless it's clearly necessary and it's being monitored. And usually this wouldn't be something that you would be comfortable doing as a primary care nurse practitioner. We're going to move on now to drugs that work on the RAS system, or the renin-angiotensin-aldosterone system. There are 3 types of angiotensin. We have 1, 2, and 3. And before considering the physiology of the RAS system together, we need to figure out how these angiotensins play a role in the system itself. Now, angiotensin 1 has a weak biologic activity, and it's a precursor for angiotensin 2. Angiotensin 2 has a strong biologic activity, and angiotensin 3 is actually formed when angiotensin 2 is degraded, and angiotensin 3 has a moderate biologic activity. Angiotensin 2, we're going to spend a little bit more time talking about in general, is formed through 2 sequential reactions. First, it's catalyzed when renin comes to play, and then second by ACE, or angiotensin converting enzyme. Remembering, renin catalyzes angiotensin 1 from angiotensinogen, and this reaction is a way to move towards angiotensin 2 formation. Where is renin produced? Actually in the kidneys, in the juxtaglomerular cells, and it undergoes controlled release into the bloodstream, and where it finds the angiotensinogen, it's going to cleave to it, and it turns it into angiotensin 1. Because renin catalyzes the next step to angiotensin 2 formation, renin has to be released into the blood and act appropriately. So what regulates renin release? Renin is triggered by multiple factors. It will increase in response to low blood pressure, low blood volume, or the plasma sodium content. It will even be released when there is renal perfusion pressure differences. Now, renal perfusion is important. When there's reduced pressure, we have to think about the important stimulus for renin to release, and it can actually occur when there's stenosis of renal arteries, reduced systemic blood pressure overall, or reduced plasma volume. So what can reduce your plasma volume? Think about dehydration, hemorrhaging, or if you have chronic sodium depletion. Remember, water follows sodium. However, some of these factors that will cause these scenarios from happening actually promote renin release through the activation of the sympathetic nervous system. So, when the sympathetic nerves increase the secretion of renin by causing the stimulation of the beta 1 adrenergic receptors, this is occurring at the juxtaglomerular cells. The suppression of renin occurs opposite to what causes it to be released. Naturally, when renin secretion is inhibited, it's because there is elevation of blood pressure, blood volume, or plasma sodium content. So, blood pressure, volume, and plasma sodium content will increase in response to renin being released. So, if we suppress it, then we are going to also suppress these things too. It's regulated by the negative feedback loop. Angiotensin converting enzyme, or kinase 2, catalyzes the conversion of angiotensin 1 into angiotensin 2. And it's located in the luminal surfaces of our blood vessels. The vasculature of our lungs has an especially rich amount of this enzyme, and because it's so abundant, conversion of angiotensin 1 into 2 occurs instantaneously, almost, after angiotensin 1 is formed. ACE is a relatively non-specific enzyme, and it acts on a variety of different substrates, in addition to angiotensin 1. When angiotensin 1 is being activated, we refer this enzyme as ACE. However, the enzyme is acting on other substrates. When it acts on other substrates, we actually call it something else. So we can also call it bradykinin or bradykinin. And we refer to this enzyme as kinase 2. That's why I said earlier angiotensin converting enzyme, or ACE, and it's also called kinase 2. But remember, we're going to call it ACE here because we're talking about it in terms of working on the heart, or the substrate of angiotensin 1. So just a review of the RAS system and how it affects your blood pressure. It helps to regulate your blood pressure because of the negative feedback loop. Things that can actually lower your blood pressure will turn the RAS system on. Okay, so if there's dehydration, low fluid, this is going to decrease your blood pressure. Your RAS system is going to kick in so that it could increase your blood pressure. And the opposite is true. The RAS system contributes to blood pressure control, and its role is to create a normal volemic state, meaning that the pressure is always where it needs to be, not too high and not too low. The system can be a major factor in maintaining your blood pressure even when you are hemorrhaging, you're dehydrated, or there is sodium depletion. But it can only work for so long. It's there to help with the initial ability to cause normal volemia. Now, the RAS system acts through angiotensin 2. It raises your blood pressure through two processes: vasoconstriction and the renal retention of water and sodium. The vasoconstriction is going to increase your blood pressure because it increases the total peripheral resistance of pressure. And the retention of water and sodium is going to raise your blood pressure because it's going to increase the overall blood volume, right? It's not allowing this diuresis. The vasoconstriction can actually occur within minutes to hours of the RAS system being activated and can raise your blood pressure pretty quickly. However, days, weeks, or even months are required for the kidney to raise the blood pressure by increasing blood volume. So the first of the two basic processes is really what is causing the major increase in blood volume. Again, that is the vasoconstriction. Angiotensin II acts in two ways to promote the renal retention of water. It constricts the renal blood vessels and it produces renal blood flow, thereby reducing your GFR. Secondly, angiotensin II is going to stimulate the release of aldosterone from the adrenal cortex. Once aldosterone begins to act on the renal tubules, it's promoting the retention of sodium and water and excretion of potassium. In addition to the traditional RAS system, angiotensin II, when it's produced in the blood and carried to our target tissues, it's produced in our individual tissues, and it permits discrete local effects of angiotensin II that's dependent on the main system. As a result, drugs that inhibit ACE can't completely block angiotensin II production because it's also in our tissues. You can see from these two charts the list of ACE inhibitors. Some ACE inhibitors are solely only approved for hypertension, where other inhibitors or ACE inhibitors can be used for hypertension in conjunction with heart failure, diabetic neuropathy. Think of captopril as being one of those medications. So this chart will show you what doses are appropriate to start with and where you can progress from there as maintenance doses, and also what they are available in capsules, tablets, and how many milligrams. Sometimes we will prescribe ACE inhibitors as a combination drug with hydrochlorothiazide. So just like we talked about in our diuretic discussion, hydrochlorothiazide is a first-line treatment for hypertension, and if it's not working, we can always combine with adding an ACE inhibitor. Well, we actually have tablets that are combo tablets, and we have ACE inhibitors and hydrochlorothiazide together. Now, there's some here that are not just a combination of hydrochlorothiazide and ACE inhibitors, and you can see that one is amlodipine being mixed with benazepril with the trade name of Latrel. So please use this chart to help distinguish the difference between the different medications. Now, ACE inhibitors are relatively safe to use, but they do have drug interactions. We wouldn't want to use it with a diuretic medication because remember, it can intensify that first dose hypotension, and it can also interact with the way the diuretic is working on the patient's RAS system. In terms of the hypotensive effect of an ACE inhibitor itself, it's often an additive with other antihypertensive medications. If we're already using a diuretic like a thiazide, specifically hydrochlorothiazide, but also if we're using it with a vasodilator or other calcium channel blockers. When we add an ACE inhibitor to an antihypertensive regimen, these doses have to be regulated and they require a reduction. Think about drugs that raise your potassium level. ACE inhibitors increase the risk of hyperkalemia because, as we've talked about previously, when we have potassium supplements and potassium-sparing diuretics and we're using ACE inhibitors, we're going to get hyperkalemia. And it increases because ACE inhibitors are suppressing that aldosterone secretion. It's reducing the excretion of potassium. This is very important to remember. And in order to minimize that risk for hyperkalemia, you don't want to use an ACE inhibitor if a patient needs potassium supplements, potassium-sparing diuretics are being used. You don't want to prescribe ACE inhibitors with lithium because it can cause the lithium in the body to actually accumulate to very toxic levels, and you cause lithium toxicity. You have to monitor lithium levels very closely if there's no other choice for medication. When you use NSAIDs, aspirin, ibuprofen, it can actually reduce the antihypertensive effects of the ACE inhibitor. Calcium channel blockers are the next classification of drugs that we can use for hypertension. We also use calcium channel blockers in addition to treating hypertension for angina and cardiac dysrhythmias. Their effect is primarily on the heart and the blood vessels. And both categories of calcium channel blockers, the dihydropyridines and the non-dihydropyridines, are going to be talked about in the next few slides. CCBs prevent calcium ions from entering the cell. They have the greatest effect on the heart and the blood vessels because they are working at the calcium ion level. They are helpful, but there is a controversy about using calcium channel blockers with patients that have hypertension and diabetes. And I want you to look up in the literature what the controversy is and to make note of that. The first calcium channel blocker we're going to discuss is the prototype verapamil. It's also a brand name under Callen, Verilin, and Covera. It falls under the classification of a non-dihydropyridine, and it blocks the calcium channels in the blood vessels and in the heart. The major indications for using verapamil is for angina, essential hypertension, and cardiac dysrhythmias. And it was the very first calcium channel blocker available, so this is why we're using it as the prototype. Overall, the hemodynamic response is the net result of the direct effects on the heart and blood vessels and also the reflexive responses. First, we'll talk about the direct effects. It actually has 5 direct effects, but one is the most important. Of all the direct effects, the reduction in AV conduction is the most important. So it blocks the AV node by decreasing the AV nodal conduction, that being the most important. But it also does block the peripheral arterioles from its reaction, which will cause dilation, and thereby it's going to reduce arterial pressure. It will block the arteries and arterioles of the heart, which will increase coronary perfusion. It actually blocks the SA node, which is the pacemaker node that reduces your heart rate, and blocks the myocardium by decreasing the force of contractility. But again, the most important is the reduction of AV conduction. Indirectly, however, it does lower blood pressure by activating the baroreceptor reflex. It causes an increased firing of the sympathetic nerves to the heart, and then norepinephrine is released, acting as an agent to increase your heart rate, AV conduction, and the force of contraction. However, because these same 3 parameters are what are being suppressed by the direct actions of verapamil, these will neutralize each other. So the net effect is going to be that we're going to have simply vasodilation accompanied by reduced arterial pressure and increased coronary perfusion. In terms of pharmacokinetics, it takes about 30 minutes for the drug to start to work. It can be administered orally or intravenously, but while it's being absorbed orally, it's going to undergo a first pass through the liver. So consequently, only 20% will reach the systemic circulation. It will peak in 5 hours, and it's eliminated primarily by the hepatic metabolism, and it is eliminated by the liver, reducing the amount of the drug will be really important if you need to provide this type of calcium channel blocker to a patient that has hepatic impairment. Okay, so again, it's because it's being eliminated by the liver that you have to think about our patients with liver disease. Primarily, we use it for angina pectoris, essential hypertension, and cardiac dysrhythmias. In terms of angina, the drug is approved for vasospastic angina and the type of anginas that cause a lot of pain. Because of this vasodilation, it usually will relieve that pain and pressure. With essential hypertension, it's not typically a first-line treatment. Usually we use it as a second-line agent for chronic hypertension after thiazide diuretics. It will lower your blood pressure because it's dilating the arterioles. Cardiac dysrhythmias can also be treated with verapamil. If you give it IV, it can slow your ventricular heart rate. If you have patients that have AFib, aflutter, or if they have SVTs or supraventricular tachycardia, because remember, it's stopping that conduction from the SA and the AV node, so it can't move through the Purkinje fibers to the ventricles. When we are able to suppress this impulse conduction through the AV node, it's not going to allow that conductivity from the atria to move to the ventricles at an excessive rate, thereby slowing down the heart rate. So we can therefore release aflutter, AFib, and again, also SVTs. There are some common adverse effects of CCB, if you want to call it constipation adverse effect. It does cause many patients that take calcium channel blockers constipation. That's one of the main reported symptoms, along with dizziness, flushing of the face, headache, and lower extremity edema, feet and ankles mostly. It can also exacerbate cardiac dysfunction in patients that already have bradycardia, because remember, if we're using this drug that acts upon the SA node, it's going to slow the heart rate. Also, if you have someone that already has AV block, because you're decreasing the effect on the AV node, thereby not allowing the ventricles to contract. It does not play nice with digoxin or beta adrenergic blocking agents, as well as grapefruits. So you will have an interaction. In terms of digoxin, digoxin suppresses the impulse conduction through the AV node. So these drugs are being used concurrently. The risk of heart block or AV block actually will increase. So you have to monitor closely if you need to use a calcium channel blocker and digoxin together. Verapamil also increases the plasma levels of digoxin by about 60%. So you do put your patient at an increased risk for dig toxicity. In terms of the beta adrenergic blocking agents, if you use a beta blocker and verapamil, they have the same effect on the heart. So your heart is going to decrease in terms of the rate, the AV conduction, and the contractility. And so when you use them together, the risk of excessive cardiosuppression increases. So to minimize this risk, we shouldn't administer these drugs together. And if you really need the effect of both, you would want to administer them several hours apart. Grapefruit juice can inhibit the intestinal and hepatic metabolism of many drugs, and this is one of them. And originally thought that grapefruit juice caused significant interactions with calcium channel blockers, but there is new evidence that actually reveals that it's the phenylidipine and the nifedipine that carry the highest risk, not so much verapamil. But these drugs can still interact with grapefruit juice. So we want to make sure that we are paying close attention to that. And it's not just verapamil, it's also amlodipine and diltiazem as well, which we're going to talk about. What diltiazem? We also know that is a non-dihydropyridine. Diltiazem also is known by Cardizem, Dilacor, Tiazac. There's lots of many brand names of this calcium channel blocker. Again, blocking at the level of the heart and the blood vessels, and their actions and their applications are very similar. It will lower your blood pressure through the arterial dilation, and it has direct suppression acting on the cardiac blood vessels, as well as the reflexive cardiac stimulation, again having net effect. We can also use this for angina pectoris, essential hypertension, cardiac dysrhythmias as well. A little bit different here, the onset is very rapid and it peaks within 30 to 60 minutes. It's eliminated by the liver first pass, so the bioavailability is 50%. Adverse effects, again constipation, but it's a little bit less than verapamil. But you will have that dizziness, that flushing in the face, headache, lower leg extremity edema. The other thing that is very common with calcium channel blockers is it will cause a chronic eczematic rash in our older patients. It does exacerbate cardiac dysfunction in patients that already have bradycardia, heart failure, second degree or third degree heart block, and we talked about the reasons why. Same interactions with these drugs. Our next set of drugs that we'll talk about are vasodilators. If we need our patient to be able to vasodilate, there are many drugs that can do this. However, vasodilators are set apart because they are directly acting on the smooth muscle in the arterioles and the veins to promote that vessel relaxation. That's their true mechanism of action. And there are two drugs that we're going to talk about in a little bit more depth in the next few slides, hydralazine and minoxidil. Vasodilators are used to treat hypertension and heart failure. And though there are other types of antihypertensives, we use vasodilators because, again, they act directly on that smooth muscle in the arterioles and the veins, and they're producing a net effect of vessel relaxation. Vasodilators differ from one another with respect to the types of the blood vessels that they affect. Both hydralazine and minoxidil will produce a selective dilation of the arterioles. Another medication that is sometimes used is nitroprusside, and this will dilate both the arterioles and the vein. The selectivity of a vasodilator really determines its hemodynamic effects. So for instance, if you have a drug that will dilate the arterioles or the resistance vessels, this is going to cause a decrease in cardiac afterload. Remembering then this is the force that your heart works against to pump blood. By decreasing afterload, arteriolar dilators will reduce the cardiac work while also causing cardiac output and tissue perfusion to increase. In contrast, if you use drugs that dilate the veins, they're going to reduce the force with which blood is returned to the heart, and this is going to reduce ventricular filling. This reduction in filling decreases your cardiac preload, or the degree of stretch of the ventricular muscle before contraction occurs. This in turn is going to decrease the force of ventricular contraction. The vasodilators as a group, they have a broad spectrum of uses, but the principal indications are essential hypertension, a person in hypertensive crisis, angina, heart failure, and myocardial infarction. The way we use a particular drug is determined by its pharmacological profile. And so we want to think again about, well, what route of administration is going to get the job done the fastest, if that's what we need. The site of vasodilation, so thinking about, is it going to happen in the arterioles, veins, or both? So do we need better afterload, better preload, or do we need both? And also, you want to think about postural hypotension. The underlying cause of postural hypotension is the relaxation of smooth muscles that occur in the veins. And so, because venous relaxation, gravity causes blood to pool in the veins, decreasing venous return to the heart. When we have reduced venous return, this is going to cause a decrease in cardiac output, and therefore, the blood pressure is going to decrease correspondingly. Hypotension from venous dilation is pretty minimal in recumbent subjects because the effect of gravity on venous return is small when we're lying down supine. Let's talk specifically about hydralazine for a second. Thinking about the cardiovascular effects, it does cause selective dilation of the arterioles, and it has very little or even no effect on the veins. Therefore, this is going to result from a direct action on the vascular smooth muscle itself. And although the mechanism is unknown, we know that in response to this arterial dilation, we'll have peripheral resistance and arterial blood pressure fall. Additionally, your heart rate and the myocardial contractility will increase because of the reflexive mechanism that kicks in. And because hydralazine is only acting selectively on your arterioles, then you don't have to worry as much about postural hypotension. It's readily absorbed after PO administration, and you'll usually get the effects in about 45 minutes and lasts about 6 hours. However, if you need a faster mechanism of action, you would choose a parenteral administration because you'll get the effects of vasodilation within 10 minutes, and it usually lasts about 2 to 4 hours. Hydralazine is inactivated by a metabolic process known as acetylation, and the ability to acetylate a drug is genetically determined. There's some people that can acetylate much faster than others, and some people will acetylate drugs slower than others. This is clinically significant because individuals who acetylate hydralazine slowly, they are likely to have higher blood levels of hydralazine, and therefore it can result in an excessive vasodilation and additional side effects. So to avoid this accumulation of hydralazine or an increase in blood level, we need to make sure that we reduce the dosage in patients that we know to be slow acetylators. We use hydralazine primarily for patients that have essential hypertension, but we can also use it for heart failure as well. When we use it for essential hypertension, we almost always use it with a beta blocker, and this is because we have some reflexive side effects that can occur with just using hydralazine. Because we're lowering that arterial blood pressure, it can trigger the reflexive stimulation of the heart, causing your cardiac muscles to work harder. And if they work harder, they're going to need more oxygen, so that demand is going to increase. Because hydralazine-induced reflexive tachycardia is very severe frequently, this drug is combined with a beta blocker. We also use it for heart failure. It's usually in combination with isosorbide dinitrate. And it can be used for short-term therapy to reduce the afterload in patients that have heart failure. When we do use it prolonged amounts of time, our patients will build up a tolerance to hydralazine. We do have a hydralazine-induced hypotension that doesn't usually happen, but if it happens, it's because sodium and water is being retained, and this is going to correspond with an increase of blood volume naturally, right? So what you could do is use a diuretic to help prevent further volume expansion. Another side effect of hydralazine is systemic lupus erythematosus-like syndrome. And hydralazine can actually cause this acute rheumatoid syndrome, and it really resembles lupus.
However, it's not true lupus. But your patients will exhibit symptoms of muscle pain, joint pain, fever, nephritis, pericarditis, and you might even get the presence of ANA, or anti-nuclear antibodies, if you tested them. The syndrome occurs mostly frequently in those patients that are known to be slow acetylators, and it's rare when dosages are kept below 200 milligrams per day. If your patient does have a lupus-like reaction, hydralazine has to be discontinued immediately. And though the symptoms can be reversed, it usually takes about 6 months or more to actually resolve. And in some cases, that rheumatoid symptom that you get will persist for years. Some drug interactions that you want to think about, remembering that we can combine hydralazine with a beta blocker to protect against that reflexive tachycardia, and we can use it with a diuretic to prevent sodium and water retention. But drugs that lower blood pressure will intensify hypertensive reactions to hydralazine. So you never want to use it with another antihypotensive drug that can really tank the blood pressure. So if you need to use it with another antihypertensive, you want to make sure that you are monitoring closely because you want to avoid excessive hypotension. When we treat for heart failure, hydralazine is usually combined with other drugs that dilate the veins. Again, with the isosorbide. Moving on to minoxidil now. And minoxidil produces more intense vasodilation than hydralazine. And this is because of the mechanism of action. It causes more severe adverse reactions as well. And even though it is very dangerous, it can be very effective. So, though it's very effective, it can be very dangerous. And we really reserve the use of minoxidil with patients that have severe hypertension that is not being reduced or unresponsive with other safer antihypertensive drugs. So like hydralazine, minoxidil will produce a selective dilation of the arterioles, and it doesn't have venous dilation, or really little, so you're not going to get that same effect. So again, postural hypotension is very low. The vasodilation here is also working directly on the smooth muscles, and it can be first metabolized to monoxidil sulfate. When it becomes this metabolite, it's going to cause potassium channels in the VSM to open. This is going to result in an efflux of potassium that's going to hyperpolarize these cells, reducing their ability to contract. Minoxidil is rapidly and completely absorbed after PO administration, with a max effect at 2 to 3 hours, and then it will gradually decline. And sometimes, because the residual effects are declining kind of slow and persistent, you can have effects up to 2 days. The metabolites are going to be eliminated in the urine, and the half-life is about 4.2 hours. We use minoxidil just like we use hydralazine for for hypertension, but remembering this is going to be reserved for those with severe hypertension. To minimize the adverse effects, though, again, same ones as hydralazine: reflexive tachycardia, expansion of blood volume, pericardial effusion, though, minoxidil should only be used with a beta blocker and an intense diuretic. We also have sodium and water retention that we can combat with using a loop diuretic. We can also use it with a thiazide diuretic as well, but if that volume expansion is so severe, you want to go with the loop diuretic. The other adverse effect worth mentioning is hypertrichosis, and this happens in about 80% of patients that take minoxidil for about 4 weeks or more. Hypertrichosis is excessive growth of hair, and it begins on the face, and later it develops in the arms, legs, and back. It appears to result from a increased proliferation of the epithelial cells at the base of the hair follicle. We think that vasodilation is also involved with this excessive growth. Many patients find hypertrichosis both unmanageable and intolerable, and they will refuse to take the treatment. Now we're going to move on to drugs used for hypertension. There are two broad categories of hypertension. There's primary and then there's secondary. With primary or essential hypertension, there is usually no identifiable cause. It's chronic and a progressive disorder, and most of the time it affects our older adult patients, African Americans, and postmenopausal women. It can't be cured, although we can treat it. It is a lifelong condition. And you will hear the terminology essential hypertension and primary hypertension used interchangeably. Remembering that this gradual rise in blood pressure is going to increase over the rest of the patient's life. And in the US, about 30% of adults have primary hypertension. Secondary hypertension is defined as the elevation of blood pressure brought on by identifiable causes. Because we can tell that there is an identifiable cause, most of the time we try to treat the cause instead of just giving an antihypertensive medication for symptomatic relief. So as a result, some individuals can actually be cured from secondary hypertension because you're going for that underlying cause. When a cure is not possible, however, secondary hypertension can still be managed with the same drugs that we use for primary or essential hypertension. We know that there are consequences of not treating hypertension. It will increase your risk for worsening heart disease like myocardial infarction, heart failure, angina pectoris, things that we already previously know. And so as a result, we need to educate our patients against non-adherence of the medication and making sure that they are checking periodically, if not daily, depending on how severe their hypertension is, so that we are making sure that the pharmacological treatments that we're providing are meeting that need. In worsening conditions, uncontrolled hypertension will start to affect not only your heart, but it will start to affect your kidneys and also promote increased risk for stroke. Let's talk about the different classes of antihypertensives, and many of these drugs you're very familiar with already. We've used diuretics as a mainstay of antihypertensive therapy, and when we use it alone, we can reduce blood pressure, but they can also enhance the effects of other hypotensive drugs. So make sure you know what the effect could be, because you don't want excessive hypotension and move the problem in the other direction. We can also use antiadrenergic drugs or sympatholytics, and these suppress the influence of the sympathetic nervous system on the heart, the blood vessels, and other structures. And they are widely used for hypertension. Think of the categories like beta blockers or alpha adrenergic blockers, A2 agonists. Calcium channel blockers, remembering that there are two groups, the dihydropyridines and the non-dihydropyridines, like verapamil and diltiazem. They are promoting dilation of the arterioles, and additionally, verapamil and diltiazem, they have a direct suppressant effect on the heart. And we've already talked about the pharmacology of calcium channel blockers previously. We also have drugs that suppress the renin, angiotensin, aldosterone system. And because the RAS system plays an important role in controlling blood pressure, the drugs that suppress this system are, especially the ACE inhibitors, they're going to play a significant role in controlling hypertension. And that basic pharmacology we've discussed previously.